Welcome to this week's webinar on subluxation or pathomechanical hypermobility. But first, this is about torticollis. Can you list 5 causes in both adults and children? 5 in total, not 5 of each. Although if you can manage that, well done. First, let me say what this subluxation is most definitely not. It is not how an orthopedic surgeon would define a subluxation. That is a partial dislocation that is visible on X-ray, MRI, CT or other form of imaging. It does, however, conform to many of the behaviours of that entity in that it does limit movement, it is reversible by manipulation, and it is related to instability, although the cause-effect sequence is reversed. It differs in that it is not visible on imaging, it is not as debilitating, it has not been definitely proven to exist, it is rarely caused by trauma, although it might be triggered by it, and it is very commonly seen in the orthopedic therapist practice. So what is it? There is an operational definition in the form of an illness script later, but in short it is a biomechanical dysfunction that causes hypermobility or pathomechanical hypermobility that has characteristics that differentiate it from other biomechanical hypermobilities. It can be deduced from the history, but only demonstrated on biomechanical examination of the spinal or peripheral joints. Let me also say that while this is my personal take on the subluxation, the model did not originate with me, but any modifications that there might be from an original model may be mine. Who can remember? So, what is in a name? In this case, not much. I'm using the word subluxation because it is what I am used to and what I have used for decades. But as long as a term is defined, then it really doesn't matter too much, although it does tend to unnecessarily upset physicians, particularly orthopedic surgeons, and make them more skeptical than they usually are. It has other names. If there weren't as many syllables, I would prefer pathomechanical hypermobility. But it is also called a jam joint, an end range lock, or an ERL, ERL, but this has 2 drawbacks. One relates to the model I am describing, and the other is I can think of another ERL that would not like people saying, I have an ERL in my neck. As I say, I don't really care what it's called as long as we can agree on a definition, and here it comes. I favour a descriptive definition that the joint is stuck somewhere between the physiological and the anatomical barriers of the joint. The physiological barrier being the dynamic restraint and the anatomical the passive. The normal everyday range is between the dynamic barriers, as if the passive barriers are frequently taking the stress, then they break down. The Charcot joint is of this nature but taken to a much larger degree. In this slide, it shows a hypomobility to be at the beginning of the flexion range, so that the end field of flexion is relatively normal, while any movement into extension is abnormal and restricted. That is, the flexion end field is quantitatively normal and the extension end field pathomechanical. The loss of range is not at the end of range, but out of the beginning of range. It also explains the how and why of manipulation. The manipulation is always against the direction of the worst end field and never into the normal end field. This of course makes sense and fits the model. If any of you are wondering why you were taught to mobilise in the plane of the joint, that is in the most easy of the movements, there are 2 reasons. One is sensible and the other is due to the instructor not thinking but regurgitating. The first is that if you are mobilising for pain, you want the least possible risk of causing pain, so you mobilise away from the pain and usually away from the most restrictive movement. The second, less digestible reason is that this is the way the instructor was taught and this is what they're going to teach. I model the subluxation following insufficient articular stability of the joint. leaving it dependent on dynamic stability as the joint surfaces are not sufficiently congruent due to cartilage loss from degeneration to maintain normal range of motion, or more likely, normal quality of range of motion. An analogy is a sliding door in your house. It can be stopped from closing because of clothes under the door or by coming off of its guide rail. In both cases, the door is unclosable, but the feeling of what is stopping the closing is different in each case. You get a much harder feel when you try to move it when the rails are off than you do with the clothes. To get the door moving again when it is off the rails, you need to jiggle it about until it is back on them again, while you have to move the clothing, which means moving the door backwards and forwards until the clothing is free. The clothing blocking the movement is meant to represent a pericapsular stiffness, while the off the rails analogy, and this is getting just a little bit close to home at the moment, represents a subluxation. The jiggling is manipulation and the back and forward motion is mobilization. Jiggling may move the clothes, but this is better done by steady pressure, while steady pressure will do nothing to get the door back on the rails. The question that naturally arises is what keeps it stuck? Explanations include meniscoid inclusions, synovial inclusions, deficits in a degenerative hyaline cartilage, labral entrapments, and so on. It might be that any and all of these are true, but I prefer to think of it as a loss of smooth running and consequent jamming. That is, I know, no real explanation, but it shifts the problem onto the biomechanics rather than on the structure, and I prefer this. And as I said, modelling is about preference as well as effectiveness. As none of these explanations have so far been proved by research, and all are equally likely or unlikely depending on your perspective, and all would fit the model, it doesn't matter which one you pick. So let's define the term subluxation descriptively. It is a hypomobility that results from pathomechanics rather than structural shortening of tissues or inclusions, such as fibrosis, meniscal or cartilaginous intrusions. The hypermobility is reversible with inadvertent movement or accidental or deliberate manipulation. This slide shows a typical presentation of the subluxation, but of course outliers do occur and should also be explainable by the model if it is to be a strong model. We shall look at the outliers later, but for now let's stick with the usual presentation. Before so, I should define episode in this context. It is not the period from one pain to another, but the period between episodes' onset and its termination. During that time, there may be periods when there is not pain, for example, with rest or particular postures or activities, but it comes back again when those activities or postures are finished. If you like, there must be times when the patient is able to do everything and not hurt, to say that the model is finished. So each episode usually lasts between a week and 3 weeks, the time getting longer as the condition progresses as the time between the episode shortens. The pain is moderate, as is any referral. Any functional loss is not obligate, that is, the patient chooses to curtail function but is not forced to. Functionally, there is a dominance of impairment, such as bigger problems with flexion activities than extension, and the range of motion shows this clearly with only one movement type being painful. This is also seen on biomechanical testing, where only one passive physiological intervertebral movement and one passive arthrokinematic movement is lost, and this is often the conjunct rotation. The end feel on biomechanical testing is pathomechanical or jammed, as opposed to the stiff end feel of a pericapsular restriction or a bony end feel of, say, spurs, osteophytic spurs. But if the sublux joint is also inflamed or severely painful, both of which are atypical, then it might be spasm or guarding respectively. And lastly, it is treatable by manual therapy, particularly manipulative therapy, but this treatment becomes less effective as the condition progresses. So often what you see in the patient's history is, I've had this for a long time, it comes and goes. I saw the chiropractor and he used to be able to clear this up in 1 or 2 treatments, but recently it's been taking longer. And the last time I went, it couldn't help at all. This is the typical thing. I have briefly discussed modelling in previous webinars, and this entire webinar is pretty much about modelling the subluxation. Modelling is about explaining observations and what we can predict which interventions will be most effective. This will be my view of the pathomechanical dysfunction that is most commonly termed as subluxation. Like all models, it is not the truth, but an explanation of the facts that is predictive. As such, there is no need to be consistent in its use. If that makes you uncomfortable, understand that scientists will change their model of a phenomenon depending on what they want from it and how to get the correct answers from the calculation. It is just that one model allows the easier use of calculations or prediction than another. So this is not the truth, and a model should be modifiable as more facts become evident. So on average, what we have is a biphasic condition that causes moderate pain, elective functional loss, unidirectional impairment and hypomobility, and a jammed end field. But probably the most important fact to reconcile is that a single manipulation can restore full function, pain-free state and full mobility both on biomechanical and on range of motion testing. Given the episodic nature of the condition, the end field, and the fact that it responds to manipulative therapy, structural tightness of the capsule and ligaments are precluded as causes, and the problem must be one that can come and go. This really only leaves a mechanical or neurophysiological issue. Either the joint is stuck or the muscles are hypertonic, and both would explain the clinical presentation and effectiveness of manual therapy. If the issue is solely neurophysiological, then mobilization should not give lasting relief of sometimes longer than 3 months without any rehabilitation. While if it is mechanical, then manual therapy can explain that exactly. In fact, it is most likely that both mechanical and neurophysiological factors obtain. But my view is that at least one of the neurophysiological phenomena that is used to explain observations are consequent, not causal to it, or another allows the subluxation to occur rather than maintain the subluxation. The pain from the subluxation would explain the hypertonic muscles via segmental facilitation, but again, this is consequent to the subluxation. On the other hand, reflex inhibition, which results in weakness and hypertonicity, would explain the onset of the subluxation via the loss of dynamic stability, which is dominated by facilitation once the pain starts. In non-painful subluxations, no hypertonicity is seen, only hypotonicity. We have a unidirectional hypomobility because the instability is unidirectional and the weakness is patterned around the joint to give essentially a PNF pattern of weakness, which is in the main unidirectional. For example, flexion plus adjunct movements such as rotation. I cannot give credit to anybody else for the model, not because it's mine, but rather because I have no idea who formulated it. But it was probably a chiropractor or an osteopath. But like all good models, it should explain facts and make predictions regarding behaviours and interventions. I will, however, take the credit or the blame for giving it the name phase transition model. So, on with the show. So, with a nod and an apology to physics and chemistry, the true sciences, I would like to term this model phase transition. It really isn't very much like true phase transition, which is a change in the physical properties of a substance or a system without a change in matter of the substance or system. An example is water to ice to steam, liquid to solid to gas, and it involves temperature and pressure changes that alter volume, viscosity and other properties. The way I am using the term is that the behaviour of the joint changes without any structural change, going from mobile or even hypermobile to hypomobile and from unstable to hyperstable. There is an underlying articular instability that periodically loses dynamic stability or encounters a force that overcomes the dynamic stabilizer and allows the joint to get stuck at one end of its range, often the conjunct rotation rather than the primary movement. Attempts at moving it out of the stuck position results in the jammed end field and movements into the subluxation, a relatively normal end field, but frequently with a softer capsular end field of hypermobility. The pain can either be present on moving against the abnormal or against the normal end field, that is, out of or into the subluxation. And very often the subluxation isn't painful at all, but stresses out joints that become painful. Okay, so looking at the outliers. First, there has to be a first episode, obviously. And this is often triggered, but not caused by trauma. Motor vehicle accidents in particular cause at least triggering this. If it isn't the trigger and is a cause, then it would have to basically damage healthy tissue. And the pain would be extremely severe and the recovery extremely long. Healthy tissues take a huge battering before breaking down. But often the first episode is the worst and often occurs with trauma such as car accidents. As the condition progresses, the episodes last longer and the intervals between them become shorter, eventually and sometimes leading to one long episode, which of course is no longer episodic. But there will be a history of episodic pains leading up to this. Atypically, the pain can be severe, and this might be due to inflammation, or it may be due to compression of very sensitive structures, in which case there is also likely to be the more referral or spasm or garden infills and multidirectional movement loss and obligate functional loss. These are not really signs and symptoms of subluxation per se, but the signs and symptoms of moderate pain. Neurological signs and symptoms occur because the subluxation is compressing, distorting, or interfering with the vascular supply to the neurological tissues. The most common in my experience is the first rib subluxation triggering thoracic outlet syndrome and an extension subluxation into an already stenotic transverse canal causing radiculopathy. Otherwise, neurological signs and symptoms should be viewed as unlikely to be caused by subluxation, and this diagnosis is only arrived at after excluding other causes. In addition to the causes listed in this slide, there is at least one case in the literature of a 14-year-old girl suffering a torticollis due to an osteosarcoma at C2 transverse process, but the above are the most common causes. We have to be concerned with the fracture, the ARF and the infections. In both the ocular and otic torticollis, it occurs due to the patient compensating for the diplopia or the hearing loss by posturing the head to maximally see or hear better. If this is of recent onset, such as after an MVA, damage may have occurred to the brainstem, then the torticollis is correctable, but if it is prolonged, it can lead to shortening of tissues, making the torticollis uncorrectable, but still not painful. Anyway, I hope you enjoyed this webinar. The topic is quite basic, but I'm hoping I gave you an insight into the value of modelling rather than making statements of fact when there's no real substance for that. Also, I hope it gave a few more details on how subluxation may behave. So have a good week, take care, and I'll talk to you next time. Bye.